lymphatic imaging and interventions. We have experts in the field today for you, both from interventional radiology and from surgery. So we are very excited to get it started. The very first speaker is the guru of lymphatic interventions, Max Itkin, who needs no introduction. Max is not able to be with us. He's celebrating Jewish New Year, but he has a recorded presentation that we will go through. And we'll go through all the speakers for today and do question and answers at the end of the session. So if I could request the speakers to keep their time. So we get started with Dr. Max Itkin. His presentation is on management of plastic bronchitis, advanced therapeutics.
Thank you very much for inviting me. It's a great honor. Unfortunately, I couldn't be physically with you in this beautiful city, Galway, because of this old tradition, 2,000-year-old tradition that have to celebrate in certain days in the fall. Anyhow, I'll talk today about plastic bronchitis, advanced therapeutics. This is my disclosures, Gube and 3D Circ. Plastic bronchitis is a condition where the weeping lymph in the bronchial tree formates this large gelatinous rigid branching airway cast. It's often associated with cardiac, congenital heart disease, but also there's multiple non-cardiac cases that come in our direction. The underlying pathophysiology of the plastic bronchitis is that there's abnormal flow from the lymphatic system somewhere, primarily from thoracic duct, going inside the lung parenchyma. Specifically in heart failure, the cause of the plastic bronchitis is presence of a lymphatic anatomical variant and increased lymphatic flow because of a heart failure. And this last part, first part, lymphatic anatomical variant is very important. Why? Because that means that theoretically, if you correct this lymphatic anatomical variant, you can cure the disease. And what supports us in the fact that there's a lymphatic anatomical variant is that there's absolutely no correlation between severity of the heart failure and incidence of any lymphatic complication, including plastic bronchitis. That means, again, that you have to have increased lymphatic flow, but also this anatomical variant. In non-cardiac patient, the biggest risk factor is obesity. So pretty much 90% of our patients, adults and kids with non-cardiac plastic bronchitis they are obese. And of course, congestive heart failure in some patients, not necessarily congenital heart disease in adults. In some patients, there's such enormous lymphatic malformation in the chest that even without obesity or congestive heart failure, they have a plastic bronchitis. We only have a few of those. So what are the imaging findings in plastic bronchitis patient before the surgery? Ground glass opacification, before the procedure, of course. Ground glass opacification. It's a major predictor of lymphatic plastic bronchitis. You can see the different examples here. So generally, if it's not congenital heart disease, we automatically assume that it's lymphatic plastic bronchitis. The diagnostic criteria for us for lymphatic plastic bronchitis, they are obesity, characteristic casts, and ground glass opacification. So if at least two of them present, we know that the patient has a lymphatic plastic bronchitis. What we do before we start, we do some lymphatic imaging. And in this case, this is MRI on the left, normal. On the right, this is abnormal pulmonary lymphatic perfusion. Or you can do CT lymphangiography. It's as good as MRI lymphangiography. And I know that many people out there start to do this because it's much easier to set it up, but it's providing pretty much the same information. So what's the treatment? Lymphatic embolization. It could be thoracic duct embolization or selective lymphatic embolization. And we start to think more about selective thoracic duct embolization, primarily because I will tell you later that one of the long-term complication of the thoracic duct embolization congenital heart disease kids is PED. And of course, one of the very important consideration in kids with congenital heart disease is right to left shunt, because when we inject glue or Lapidol, if it's go to the systemic circulation, it will be bad. So one of the most important things before you do anything is ask your cardiologist, or if you do that, interventional cardiologist, or you can do that, is close the vena collateral. And the second one, if the patient has the fenestration, put a balloon across the fenestration. So this is how it works. This is vena collateral. Why this vena collateral is so important is because the thoracic duct empties there. So if you Lapidol go into this location, it can go easily into this vena collateral. And to remind you, vena collateral, it's a central systemic venous to pulmonary venous circulation collateral. So bypassing the heart, going directly into the systemic circulation. So you have to embolize those. This is how it works. Usually it's coils, works quite well. And the second one is, of course, to put a balloon across the fenestration. Why do we need balloon? Let's say if you have a little bit Lapidol spilled during lymphangiography, it can go into the IVC, of course, and can go through the fenestration. So we'll always put balloon. That's absolutely necessary. Of course, any procedure we start with intranodal lymphangiography. That's relatively straightforward procedure. So recently we started to think about dedicated equipment, and one of the major downside of spinal needles that we use right now is the leakage. So on the left you can see there we started injecting very nicely, and 5 minutes later you see huge leakage. Why is leakage? Because needle will pull out of the lymph node, and that's the reason there's a new needle coming on the market. It's called LMX. Meanwhile, the idea is it has like a tiny hook at the end, can go inside the lymph node and destabilize there, but also it's just a much better and robust needle than just spinal, with some ultrasound coating, and also there's a sidearm where you can inject contrast. So then we do thoracic duct access. How we do it? We see the systemically, go through everything you can, advance your wire through the inside the thoracic duct. So here's another development. And of course, this is the most critical part of a procedure, catheterization of the thoracic duct. So recently, the same company came with a second needle where they actually modified it, and you can see Shiva and this the other needle, a thoracic duct needle, where you actually can advance your wire with no problems of sharing wire. Number one, number two, it's just much sharper needle, and it's bent the way it's much easier to get inside the thoracic duct. So both of these devices come in probably, hopefully, sooner, probably 1 or 2 months in the United States, in Europe, and the rest of the world, it'll be later. So then you inject thoracic duct after you position the cutter. You can use pretty much any cutter. We use like a short one, 100 centimeter Renegade. And here you can see this is clearly abnormal perfusion of the lung parenchyma. So this is another injection. You can see that there's actually the long pathway, the thoracic duct all the way. It looks like there's absolutely no perfusion, and at the end you can see it's actually refluxing back into the hilum. So here, for example, you can do definitely selective embolization of this duct, at least try. So how do we embolize? We do use coils and glue. So why coils are important? Coils are important here. We deploy the coils is to prevent the glue from going all the way to the venous circulation, right? So it's kind of stop the glue going there. And this is a glue injection, and you can see actually glue even goes through these coils, maybe slowing down. And you have to be absolutely very, very careful, observe your propagation of the contrast, because you easily can inject it into the systemic venous circulation, and it can go somewhere it's not supposed to go. And of course, you have to flush the catheter with D5 before, and you have to just a little bit flush it, not too much, because if you flush too much, it will fill thoracic duct with D5, and glue is not going to polymerize, and our dilution 1:1 with lapidol. In some cases, you can do this interstitial lymphatic embolization. Let's say you cannot get inside the thoracic duct because thoracic duct is too small, the sternocleidomastoid doesn't exist. You can position needle inside the this lymph node that feeds this lymphatics and injector needle. You have to be super careful. Of course, it can leak out. So be careful, but definitely we use this technique. It's totally legit. There's a multiple technical aspects. So this is an example of patient that have a parallel system. And a lot of time we have 2 thoracic ducts, 3 thoracic ducts sometimes. So what you're supposed to do here, you actually supposed to, so what obviously the one on the left is probably the one that's problematic. So what can we do here? We can potentially glue it selectively, but the problem is if you have these parallel ducts, if you even go very, very selectively and even glue most of these parallel ducts, sometimes you're not successful. So here is on the right, this is our glue injection. It's just selective injection into this branch, right? So what we're going to do, we're going to start glue from this point, but try to glue all the way down to the main thoracic duct. And that's what we do here. This is a glue coming out. And while it's coming out, we slowly started to pull catheter all the way down and trying to fill the rest of the ducts. Here, you don't have to worry about embolization into the vein because there is no communication easily to be seen between this thoracic duct. And you can see I pull the catheter back and slowly glue it. I thought I glue the one leather, part of the leather, and then the other one, and patient is doing better. But then he put himself on the keto diet, and immediately symptoms recur. So you can see here, and unfortunately this patient's too big, we can do MRI. There's another parallel duct that go in toward direction in the chest. So the moment we glue him, the patient on the right is glue. Of course, the patient is doing excellent. So plastic bronchitis in congenital heart disease, it's only one paper. There's a second paper from Belgium with the small numbers. Outcomes are excellent, almost 94% significant improvement of the symptoms. In non-cardiac plastic bronchitis, the outcome even better. We will be publishing pretty soon our biggest series of 55 patients with non-cardiac plastic bronchitis. The outcome is absolutely outstanding. So, as I mentioned, the embolization is a good treatment for this condition. However, some cardiac patients develop protein-resistant enteropathy that we recently developed very good treatment as well. So we try to maintain the patency of thoracic duct if possible, embolize selectively. Unfortunately, it's not possible most of the time, but if you can, try to embolize selectively. These are the special cases that we and hopefully other groups discovered. This is a patient where presented 14-year-old post-Fontan plastic bronchitis, and his thoracic is absolutely normal. There's absolutely no flow from the thoracic duct into lung parenchyma. We did everything we can, but if you look very, very carefully on T2 imaging, you see some wiggling structure parallel to the thoracic duct. With no contrast, of course, it's T2. So we assume it's some type of lymphatic duct, and where it's close, it's very, very close to the liver. And in this case, we managed to catheterize the liver lymphatic, it's heart failure kidney, and you can see that we actually can feel these abnormal ducts, and when you inject blue dye, you can actually see the casts coming, the acidification of the submucosal perfusion. So gluing of his duct cure the problem, Here's the just a correlation between MRI and imaging, and the kid is doing very, very well. So the other case recently we done, the supply of the lymph was actually from the neck into bronchial was from the neck lymphatic nodes. So it's a rare. We have only this kind of bizarre 4-5 cases, but they're out there. So in conclusion, the plastic bronchitis is a well understood disease. We clearly understand what's the problem, what's pathophysiological mechanism. The outcomes of lymphatic embolization of plastic bronchitis are excellent. Protein-losing enteropathy in heart failure is an issue, so you have to be careful. But here you always have a selection between worse, right? So the plastic bronchitis can immediately kill child, they can suffocate, whereas PLE is just slowly degradation, and we have treatment for PLE quite good one. Technically, it's one of the easiest and well-established lymphatic procedures, primarily because thoracic duct is quite dilated in these children if it's heart failure. And we strongly advocate that should be the first treatment therapy for this patient. And thank you very much for your attention.
Next, I'd like to welcome Geert Mello from KU Leuven, Belgium, to be speaking on diagnostic nodal lymphangiography.